Okay, dear students, in this class we will be discussing the quinolones and macrolides, the last class topics in this antibiotic section. After that, we will discuss the antifungals or antiviral for the pre-med only. Okay, so by the end of this lecture, you will be able to define or describe the mechanism of action of quinolones and macrolides, compare the spectrum activity for quinolones and macrolides, the pharmacokinetic profiles, list of adverse effects, and the therapeutic indication and clinical uses for these agents. So if you look into this diagram again, you will see we will discuss here the macrolides and the quinolone. So macrolides are inhibiting the 50S unit of the protein of the bacterial protein. It is including the erythromycin is one of this class, and the ceprofloxacins belong to quinolones. They are inhibiting the messenger RNA of the bacterial cell. So we will discuss in this lecture these two classes of antibacterial drugs. Quinolones, they are where they come from. Basically, in 1962, naldixic acid was discovered by George Leisher and was named as quinolone, and useful only for the treatment of urinary tract infection. So it were very limited spectrum, only used for this treatment of urinary tract infection. So this is a naldixic acid, the structure of naldixic acid, and then the chemist and the scientist are normally studying this structure activity relation of these main parent drugs. So they include or they added some functional group to these parent drug and increases the potency of the already known drug, or they can decrease the toxicity of the already known drug. So this is one of the example where naldixic acid, this fluorine group was added to naldixic acid, and then it achieved bactericidal level in the blood and the tissues level. So it increases the distribution of this drug to the blood and tissue levels, and that's why it has improved the antibacterial spectrum of these drugs. So we will discuss these fluoroquinolones and their mechanism of action. So if you look into the mechanism of these drugs, they are bactericidal and they block the DNA synthesis. So they inhibit the DNA replication by inhibiting these two enzymes, DNA topoisomerase and DNA gyrase. So these two enzymes are essential for the uncoiling and recoiling of the bacterial DNA. So that's inhibiting the replication of the bacterial DNA. They block the bacterial DNA synthesis by inhibiting the bacterial DNA gyrase and topoisomerase enzyme, which interfere with the separation of replicated chromosomal DNA into respective daughter cells during cell division. Now, how the bacteria can evolve resistant to these class of drugs? Basically, these drugs need to enter the cell and go into inside the cell in order to inhibit the DNA topoisomerase enzyme and gyrase enzyme. So one mechanism that it can inhibit the permeability of the drug of its cell membrane or cell walls, which will inhibit the entry of the drug into the cells. Another, it can change the binding site for these drugs. So one or more point mutation in the quinolone binding regions of the target enzyme like topoisomerase or DNA gyrase, so that binding site can mutate and the drug will unable to bind to its receptor or its binding site and will become inactive in these organisms, or it can change the permeability of the organism, so the organism can change its structure and will not allow the drug to enter. Resistance to one fluoroquinolone group confers cross resistance to all members of this class. So if one drug in this class if bacteria evolve resistance to one class of this drug, then all the fluoroquinolones will become ineffective for these bacteria. It has different generation. Like the first generation, naldixic acid was first discovered, so that was effective only against gram-negative bacteria, but not Subulora species. Then in the second generation, it increases the spectrum, norfloxacin, ciprofloxacin, ofloxacins, and they have gram-negative, including Pseudomonas species, and some gram-positive Staphylococcus aureus, and some atypical bacteria, while the third generations have more spectrum, same as second generation, with extended gram-positive and atypical coverage. So levofloxacin and moxifloxacins are the third generation in this class. A fourth generation, trofloxacins, however, it has same third generations with broad spectrum and aerobic coverage as well, but it has been withdrawn due to severe liver toxicity. So it has broad spectrum, but the side effects is also increased with these drugs. And if you look into the pharmacokinetics of these drugs, they are very well absorbed after oral administration, and its bioavailability is almost equivalent to intravenous administration. It has bioavailability of almost 80 to 95%. Oral absorptions, however, this oral absorption is impaired by divalent cations such as magnesium, calcium, and aluminium. That's why these drugs should not be taken with milk or yogurt, because milk contains calcium. So calcium will decreases the bioavailability of these drugs. That's why this drug has to be taken with water. With water, it has maximum bioavailability. Most of the fluoroquinolones eliminated by renal mechanisms, so adjustment required in patients with creatinine clearance lower than 50 ml per minute. So this creatinine clearance is the diagnostic marker for the function of the kidney. So we have a proper value of this creatinine is almost exclusively excreted by the kidney, which is formed in the body. So we have proper values for these normal values arranged for these creatinine clearance. So if it goes below this normal values, then we can say that there's a problem with the kidney, and based on that problem or that function of the kidney, the dose of the fluoroquinolone has to be decreased. It has limited cerebrospinal fluid penetration, so its CNS effect is minimal. Fluoroquinolones has a number of clinical uses that include urinary tract infections associated with the gram-negative bacteria, traveler's diarrhea. Sometimes when the people are traveling due to eating unhygienic food, they can get diarrhea due to bacteria. So this GIT bacterial infection can be treated with ciprofloxacins. It can be used in the tuberculosis, prostatitis, anthrax, Bacillus anthracis. It's also one of the type of bacterial infections. A respiratory tract infection caused by the Pseudomonas aeruginosa, such as peptic fibrosis and otitis. All these can be treated with fluoroquinolones. In general, these drugs are well tolerated. However, it can have some side effects, like GIT-related side effects include nausea, vomiting, diarrhea, CNS-related like confusion, insomnia, dizziness, anxiety, or seizures. That's why it has to be used in caution with those patients who have CNS problems like epilepsy, because in epilepsy, the seizures, it will induce more seizure attack in epileptic patients. Cardiac arrhythmias, it can have some effect on the QT interval of the ECG, if you can look at this. So it should be used in caution with those patients who have problem with heart. It can damage the growing cartilage and affect the the growth of the bones. That's why these drugs should not be used in children under 18 years of age, because at that age the cartilage and bones are in the growing condition. So that can affect that growth of the cartilage and bone in those children. It can produce phototoxicity. That's why people should use sunblock, or if it is still producing phototoxicity, then avoid sun exposure, or it can stop the medication. Hypoglycemia is related to levofloxacins, and it can be like a two-way mechanism. It can be like pharmacokinetic interactions or the pharmacodynamics. Those patients who are taking oral hypoglycemic drugs, this levofloxacin increases the metabolisms of those hypoglycemic agents, and that can uh, basically these drugs can this levofloxacin can decreases the metabolism of these oral hypoglycemic agents, and that could lead to increase level of those drugs and will lead to hypoglycemia. Or it can also, pharmacodynamically, it is thought that it can increases the insulin release from the beta lactam cell. So there are different studies, however the exact mechanism is still not understood, but there are different studies which can explain this mechanism for levofloxacin induced hypoglycemia. Contraindications, so that children under 18 years of age, they should not take this drug because it will affect their bone and cartilage growth. Pregnancy and lactation, it can go into the fetus, or it can be secreted in the milk. That's why it should not be used in women who are pregnant or who are feeding their babies. Epilepsy, because it's CNS effects, this drug can they can produce or precipitate these seizures, so it can increases the condition of epileptic patients. Arrhythmias, that is associated with the cardiac arrhythmias or QT interval in the ECG. There is an important drug-drug interaction between ceprofloxacin and theophylline through inhibition of cytochrome P450 metabolizing enzyme. So this ceprofloxacin inhibits the metabolism of theophylline and can lead to increased bioavailability of theophylline. And you might recall the effect of theophylline in the anti-asthmatic drug. It's a phosphodiesterase inhibitor, and that can increases the bronchodilation. Macrolides, these are classified into two classes broadly, narrow spectrum and broad spectrum, and that include the erythromycin is the narrow spectrum, while the broad spectrum include clarithromycin, roxithromycin, azithromycin. So the identification for this macrolide is thromycin. So whenever you see this thromycins at the end of the drug, that means these belongs to the macrolide group. And if you look into the mechanism of this, it's also a protein inhibitors, but it is inhibiting the 5S ribosomal unit of the bacterial cells. So macrolide antibiotics are bacteriostatic agents that inhibit protein synthesis by inhibiting the 50S unit. So this is the 50S units that is inhibited by the macrolides. Antibacterial spectrum, it's a broad spectrum antibiotics that are active against many gram-positive and gram-negative bacteria. So therapeutic uses, it can be used for different types of bacterial infections, which include mycoplasma pneumoniae, chlamydial infections, diphtheria, streptococcal infections. All these are types of bacteria, and they are causing different types of bacterial infection. H. pylori, we'll discuss this in the anti-ulcer drugs. So it's also one of the cause for the ulcer. Syphilis, it's a sexually transmitted bacteria. So all these are types of bacterial infection, and macrolides are effective against these types of bacterial infection. Pharmacokinetics, erythromycins base is destroyed by the stomach acid and must be administered with enteric coating. So they are acid. They can be destroyed by the acidic environment of the stomach. These erythromycins. So that's why they are given in the form of enteric coated tablet. So what are enteric coated tablets? That we might have discussed before as well. But those drugs which can be destroyed by the gastric pH, they are protected in a coat, right? So these tablets, they are covered with a coat which is acid resistant, but this is degraded in the alkaline environment. So when it goes to the stomach, it remains intact, and when it goes to the intestine, there, due to the alkaline environment, this coat is degraded, and then the drug is released within the stomach and can be absorbed from the stomach. Food interfere with the absorptions. The broad spectrum macrolide are fairly acid resistant. So this erythromycins, it is not acid resistant. That's why it can be given as enteric coated tablet. While the others, they are not acid resistant, so they need not to be given in the form of enteric coated tablet. Distribution: erythromycins are widely distributed in the body, so they are widely distributed. Adverse effects include the hypersensitivity reactions, which include drug fever or skin rashes. It can produce some GIT effects like nausea, vomiting, and diarrhea. It can increase the GIT mortality by acting through the mortalin receptor, which causes the increase in the mortality of the peristalsis movement of the GIT. So that will lead to diarrhea. Hepatitis with cholecystic jaundice. So what happens in cholecystic jaundice, that the biles is blocked or retained within the liver, and that leads to this jaundice. So hepatitis is one of the side effects. Azithromycins and erythromycins are excreted through the bile, while clarithromycins is through the kidney. So clarithromycins, this is the route of excretion for these drugs. Erythromycin and azithromycins are category B drug in pregnancy, while clarithromycin is category C. So these are pregnancy categories of drugs that we have discussed in the first lecture. So that's all about the antibiotics. In this class, we have discussed the macrolides and the quinolones. So macrolides are they are basically divided into two main classes: narrow spectrum and broad spectrum. Erythromycin is a narrow spectrum, while all others are mostly clarithromycin, azithromycins. They are broad spectrum antibiotics. This erythromycin, it is destroyed by the stomach acid. That's why it can be given as enteric coated, while the broad spectrums are acid resistance. They inhibit the 5S unit of the bacterial protein, while the quinolones, they block the DNA or RNA synthesis. So they are basically transcription inhibitors. Resistance due to mutation in the quinolone binding sites or blockade of permeability. So they either inhibit the entry of the drug into the cells, because these drugs need to go inside the cell or the bacteria in order to inhibit this bacterial DNA or RNA synthesis. They have different generations, 4th generation lactic acid starting from that, and then with every generation the bacterial spectrum is increased. So that's all. That was all about the quinolones and macrolides. Thank you.